Okay, cool.
Okay, there you go.
So, sorry, I'll restart again. So, essentially, I've been doing orthodontics for about 25 years. I was based in the UK for all years, and then things changed. And to cut a long story short, I ended up in Melbourne, and specialist practice in Melbourne, and I was running two busy practices, one in Caroline Springs and one in Broadmeadows. I'd probably still been there if I hadn't been for COVID. So I had a significant bearing on my career without me realising COVID. I think I think there was a ninth lockdown that Daniel Andrews called circuit breaker lockdown. I just contacted the guy that I was running the practices for and said, "Look, I'm sorry, but I've had enough." It's just too much hard work. So I did some locum work. I went to New Zealand for a little bit. Worked in Dubai for a little bit, and also I did some work in the Caribbean for a couple of years. And I was quite keen to come back to Oz. One of the primary reasons I looked at coming to Western Australia, they seem to have a more sensible approach to pandemics and epidemics. It was pretty tough going in Victoria. And what I can understand is that I had a friend who's down in Geelong, 30 minutes from where I was based, and essentially he was practicing as normal, which was difficult. Okay, so we'll get started. One second. All right, okay. So what is orthodontics? Basically, it just means straight teeth. Translation in Greek. It's a little bit more to it than just straight teeth. In the UK, most people are primarily concerned with the front upper teeth, the social six, we call them. They want them straight, and that's it. They think that once those are straight, they're done. But there's other parts to it, and I'll come on to that in a little bit. So, clinical orthodontics, the way I look at it, I sort of split it up into sort of like three parts, really. So generally, if I see a patient, I carry out a formal assessment. So that formal assessment will be both subjective and objective. And the subjective part of it is largely based on experience. So I will look at something and I'll classify something based on my experience. But a lot of it, there are things to measure, so you get an objective measurement of what you're recording. We actually treat something that's called a malocclusion. And what a malocclusion is just a departure from the ideal. And we're not treating disease as itself. So we're treating departure from the ideal. And the assessment, it normally takes part over a set time period, maybe about 40 minutes or so. We do a formal assessment, which is a clinical examination, some specialist x-rays. I use a scanner, and I scan the teeth, and I put up the scans and talk about what's going on. Because one of the difficulties I find as an orthodontist, trying to explain things, but not using technical language. And a picture says 1,000 words. So I put a picture up and it's a lot easier to talk about. And that's just the way I do it. And it seems to work. So that's kind of what we do. And we use what we call, I use what we call an iTero scanner. And I can look at it in 3 dimensions. I can spin it around. I can show deep bites, which is really difficult to show on on patients. So I find it very beneficial to use STEM. And I think a lot of these audiovisual aids now, especially, they come into prominence when, you know, you get asked to give evidence on the behalf of somebody. And that's one of the things that they want to know is that, did you use some sort of audiovisual aids to help the patients understand what was going on? So a malocclusion itself, it can be split into three particular areas. So it's inherited, genetic, environmental factors, and specific causes. So what I'll do, I'll just get some examples up. But usually you can put one malocclusion into each one of those headings. Sometimes there's a combination, but what we'll do is just talk about it. So this is a young girl. So if you look at this image on the left-hand side, you can see things are not right. So what does everybody see on that? What would you sort of say about that?
Well, there's a couple of layers of teeth.
Okay. Yeah.
Like the canines haven't quite come.
Yeah. So she's got some crooked teeth. Okay. But me as an orthodontist, one of the things that I would first notice is that the teeth on the patient's right side, because everything's back to front in orthodontics, are inside the bite. Okay. And that's what we call a cross bite. And generally, when you get a cross bite, we look for what we call a slide. In other words, there's a departure between the bite when they're in the furthest back position until when they normally naturally bite. And the slide is basically as a result of this cross bite. And the result of that cross bite is because the upper arch or the upper jaw is narrower than the lower. And this is probably inherited. The crowding itself is probably related to the fact that the teeth are large and the jaw is small. So there's that. So we've got the crossbite, and these teeth are inside the bite, and that's what we term a crossbite. Those are outside, which are good. The other thing as well is the patient's got what we call an occlusal cant, and it's going from left to right. So it slopes downwards, so they're not horizontal. And also, as well as the crowding, which you guys spotted, she's also got small lateral incisors. So those lateral incisors are supposed to be larger than these. So lots of stuff going on. So obviously the one on the left is the start, and that's how we finished. We didn't do anything about the what we call a tusk size discrepancy, the small lateral incisors. We just left those. But I think it's a pretty big result. Nice result. And she had about 18 months of treatment. She had an expander first, okay, which is a glued-in expansion device, and I'll show you one of those shortly. And we did the expansion. We held the expansion for about 6 months, and then we used fixed glued-on braces, train tracks, to sort that out. This is what we call environmental factor. This is actually my nephew. So one Friday night, I finished work, sat down with my wife, poured a glass of red wine, just about to eat the meal, and I get a phone call off one of my other nephews. Liam's in ITU. He's been knocked unconscious, and one of his teeth has been knocked out. Can you come and see him? So essentially, my nephew had gone to train for rugby. Hadn't worn the mouthguard I'd provided for him, and his top front teeth collided with the back of somebody's head. So this tooth was snapped off obliquely, snapped off into the palate. That actually had been knocked out So that was put back in. The right central incisor was knocked out, so we put that one back in. On the left lateral, the left central and lateral incisor, what we call subluxed, which is a partial dislocation, to want of a better word. And essentially what I did is put that little splint on. So that's just a flexible wire with ceramic braces. The reason it's flexible, it allows the teeth to move. Because if you hold the teeth rigidly, they'll fuse to the bone. And they become sort of non-functional, they become ankylosed. And that's what we don't want. So after 2 years of orthodontic treatment, that's what we ended up like on the right-hand side. The actual right central incisor, I was only expecting that to last a year. It lasted 10 years. It was knocked out of the mouth. His mother picked it up, washed it off gently, and put it in her cheek. Okay, and kept it in the cheek until I got to the hospital. And then we reimplanted it, put it back in. So, yeah, so I was really, really pleased that that lasted 10 years. He's now, he's had an implant in there. Yeah, so it's fine, but we knew.
Can I ask, so in terms of doctoring and stuff like that,
Yeah,
obviously, especially ED and stuff, they would see the presentations of people getting teeth implanted at the time and sporting injuries. So what would be your recommendation?
so the ideal time is to try and reimplant it if you can, if it'll go into place within an hour.
Within an hour.
Yeah.
And,
so ideally the storage
somehow, would that be the mouth guard or
yeah,
how could they help future?
Yeah, it's either a dentist or an orthodontist.
But 90% of the time you're not going to get one of those.
Yeah, yeah. Sometimes
at night or whenever it's going to happen, it's going to be a day or two.
Well, where I used to work, there was always somebody available, a dentist or an orthodontist.
Yeah, so
yeah, but it's something you could speak to all the dentists, yeah, it's not an issue really.
Yeah,
even
I'm just asking for if this goes out and we can get the medical practitioners doing the initial point of care, so that the end point when they do get to see the dentist and you, if it's.
I think obviously if the foot itself is clean, okay, it can be stored either in milk or you can store it in the cheek. Sometimes obviously kids are reluctant to do that, so parents can do it. And some parents won't feel comfortable. And just try and get it back in really. My experience with trauma, I was a senior house officer at Max Fanks, and I wrote a trauma handbook for the department, but that was a lot of years ago. Things may have moved on. So I think if you're looking at it, try and set it up in this region, I think probably the best thing to do would be to contact maybe a pediatric dentist who has an interest in trauma in Perth, and speak to them and say, look, how can we sort of set something up to do this? And there'll be lots of people willing to help and volunteer, and that's it. In an ideal world, the pointy bit of the root should be open, have an open apex, and then you put a flexible splint in and just keep that under review until everything sort of settles. Okay, and it depends on. Liam had sort of fairly complex injuries. There were lots of things going on, but I think with him, I just ended up putting lower braces on, straighten his teeth out because the bite wasn't great. So he tilted his bottom teeth back a little bit, and the lateral incisor on the right hand side, I exposed that, put a little hook in, and pulled that down. It's handy when you've got an uncle who's an orthodontist and also was a specialist registered oral surgeon in the UK as well. So I think Liam was lucky in that I was about on site and
Yeah.
had a vested interest in making sure everything was fine. But I think if you're looking to set up a potential service, I think it needs to involve a number of people really, and somebody is looking to set up the service. I'd be happy to do it with a paediatric dentist because I've done it in the past, so it's not an issue. Yeah. So
Kevin, in the first instance, if they do have a tooth knocked out, would you prefer us to sort of like loosely reambulate and split it with like, you know, a silky split?
yeah, you can do that. Anything sort of temporary, and then just
Yeah. And so the next day or something.
even if we see them,
Yeah.
we can see them. And I can put what we call physiological splint in. That's basically just a brace. And as I say, charging wise, that can be sort of worked out beforehand.
Okay.
But yeah, if that's something that is of interest, then
Yeah, well, I'm not sure. I'm not a doctor on this.
Yeah.
It's just thinking out.
Well, from a logistical point of view, it just needs, it needs the collective community really in terms of.
And that's the issue we have here. We have lots of organisations practicing in sanitary, but then you've got the archos that acquire sanitary, and then there's all these periphery dentists, and then we're lacking dentists in the public health system. There's Cletus, and there's Cletus at the moment, I think. So you have such lack of service in that area that you know, people are sure going to present to ED or the doctor the next day and go, my tooth knocked out.
I think it's
too late, or
I think it's after an hour.
Yeah.
And everything is dried out. The periodontal ligaments dried out.
Yeah.
The prognosis is extremely poor for that sort of thing.
Okay. So this is something we educate our ED. Kind of like doctors in that initial care, what they can do. To help that person.
But often than not, obviously preservation of life takes priority.
Oh yeah.
But as you say, Liam was knocked out, but we managed to get that tooth back in fairly quickly. I just think we used a little bit of glue initially, just to temporarily tap it in. Yeah, sort of ordinary. It was ordinary dental glue. Well, it's like glass ornament. And even if you just do that temporary, that's fine. But if it's during the day, you can always give us a call. And if I'm working, I don't mind staying back. It's not a trauma patient. It's not an issue. Just give him back, really. And the third thing is a specific cause. Slide on the left. This patient is congenitally missing an upper lateral incisor. So what we did with the orthodontics, we just created some space. And then once you create the space, that's a vacuum form retainer with a plastic tooth in it. As a temporary measure, so retention. And then that's with the bridge. Nowadays, they probably wouldn't put a metal wing. That's a metal wing on this. It's glued onto the canine. They probably wouldn't put a metal wing now. It'd be a white type wing, and it would look a lot better. But it's difficult sometimes to keep track of these patients because they have the orthodontics done, and then they get the the false tooth placed by a dentist or a restorative specialist, and often than not, they think, oh, that's done. So essentially, why do we do orthodontics? You usually find that if people have got nice straight teeth, they like to smile. Okay, and from an orthodontic point of view, we look to improve both function and aesthetics, and we try to get a balanced, harmonious relationship between those. And it definitely does improve self-esteem. And if anybody's interested in that, there's lots of work being done in the UK. There's a chap called Kevin O'Brien, and he's very interested in that, and another person called Sue Cunningham. They're both professors that taught me in the past. That they're very, very good. Kevin is retired, but if you look up online, especially in regards to the psychological benefits of orthodontics, and that's only really starting to be recognised in the last 10 years or so. Yeah. Obviously, we showed that bite correction, that first one. I think if that had been left, because she was biting and sliding, it would have led to premature wear of some of the teeth. The enamel would have been lost, dentin exposed, teeth could have been a little bit sensitive, but also when they bite, she swung over to one side. So it gives the appearance of a pseudo asymmetry. So the jaw doesn't look symmetrical, either side of the midline. So that's something that we're quite keen to as well. And there's not a lot of evidence to support it, but once the teeth are nice and straight, theoretically, they may have less likelihood of developing dental decay and gum disease. It's certainly easier to clean. And whether you could say, well, whether the patient's got really nice straight teeth, so that gives them that extra incentive and motivation to keep them nice and clean. I don't know, but there's other factors that may come into play. Risks of orthodontics. I apologise for the quality of this slide, but we don't often see this. This is a slide, a picture that I had to basically borrow off somebody. So this person has had orthodontic treatment and they've got permanent marks in the teeth. I actually haven't seen this on any of my patients because generally what happens, a patient will disappear for 12 months and then comes back in. And if they haven't been following the dietary advice, they've got these little windows of demineralization. Can you see like the little squares? And it's just, they've not kept their teeth nice and clean, not followed the dietary advice, frequent fizzy drinks, carbonated drinks, there's energy drinks. And you get these marks, and once you get those marks on the teeth, unfortunately, they're permanent.
Is that after they've had surgery?
Yeah, so the braces have come off, but you can see where the braces were. See the little squares? So, and they're actually white spot lesions, but they gross really around those. And this lateral incisor, that's actually got a cavity. So there are risks associated with orthodontics, and one of them is marks in the teeth, and that's why we try to emphasize about keeping the teeth nice and clean, following the dietary advice, going for a checkup every 6 months, and preferably a clean every 3 months, just to keep on top of things. And it's just constant reinforcement, just reinforcing as much positive behavior as possibly can. Gum disease, if you don't brush your teeth, your gums are going to get inflamed. It's a lot more difficult to keep your teeth nice and clean when you've got braces on. So we have to emphasize patients must spend time brushing their teeth. Sometimes when we fix the bite, like we did I showed you that first slide, because the bite is sliding all the time while we're doing the treatment, because orthodontics does take time, sometimes some patients will get pain and discomfort in relation to the jaw joint itself and also jaw muscles. And that's largely due to the fact that the patient has difficulty trying to find a consistent bite in place, and as a result of that, they may get this problem. It usually settles down with just painkillers, and we recommend analgesia is required. We have a little self-help sheet that we normally give out as well. But it usually does settle down. If it doesn't, sometimes you have to pause or stop the treatment. I haven't had to do that in 25 years. So I don't know. Maybe I'm just lucky. I don't know. But I think I've still got some time left in practice. So I may encounter it sometimes. But we always generally tend to warn the patients about that. We've also got what we call loss of vitality. And I think when you look at people, sometimes you'll see some people, one of the teeth is dark or black. And that usually means it's died off. The nerves and the blood vessels have died off. And it's just the pigments inside because the body can't get rid of them. So in order to address that problem, they need a root canal and maybe a little bit of bleaching. But again, it's a recognised complication in patients that have had trauma to the teeth. And that can be direct trauma, as a sort of knocking into something when they were little. Or it can be a large filling or a crown, because that's trauma. Or indirectly with the bottom teeth bashing against the top ones. So that's something as well. This is something that's becoming a lot more prevalent in terms of warnings, especially with dental protection. Was the patient warned about shortening of the roots? So when you carry out orthodontics, the roots basically are going to shorten a little bit. It's usually about 0.5 mil to 1 mil. That's of no clinical consequence in the long term. But some individuals will develop significant root shortening. This is the pre-operative film of a case that I was sent as a transfer. And when I see a transfer case, I always take records. And that's what my defence colleagues recommend you do. So we took an OPT and I thought, oh dear, the central incisors roots look a little bit short. And I thought, well, sometimes it could be due to positioning or the inclination or the angulation of the teeth. So what I did, I took a little X-ray, and you can see that those central incisors are very, very short. There's hardly any bone covering that one. So the prognosis for those central incisors was not that good. So I had to break some, bad news to the patient. I didn't end up accepting this patient as a transfer case. They went back to the original orthodontist. I'd liaised extensively with him. But there are certain features, and I think if we're going to just go back to this one, and it's sometimes easy with hindsight, but there are certain features that we would look at. And you can see on the pre-operative, before the braces were put on, that the roots were a little bit blunted. And the bone levels weren't great to start with. I don't know how the orthodontist managed that. But I think if I'd continued to do the treatment, the patient would have been warned that the prognosis is what we call guarded with those central incisors and that upper left lateral incisor. Patient would have needed some teeth out to pull the teeth back at the sides to create space to align these front teeth, and then that would have been followed by continuous monitoring then of those teeth. But after we'd finished, they would have probably needed a bonded retainer, which is a little wire on the inside to act again as what we call a physiological splint. So yeah, it's when it comes to orthodontics, it's not risk-free. And the other risk of orthodontics is what we call relapse. It's an interesting term. Some people won't call it relapse, they'll call it age-related changes. The mouth is a dynamic environment. And essentially, if you don't wear your retainers after you finish orthodontics, the teeth are going to move. What we don't know is which patients the teeth are going to move, how long that movement will go on for, and if we were to basically stop wearing retainers, would there be a sort of lag period when teeth wouldn't move for a little bit and then they'd restart? So generally what we do now, we treat everybody empirically because they're not, there's some aspects of the treatment that we know the teeth are going to potentially move. Like if we close gaps, we know that if you don't wear a bottom retainer, the gaps will back up. But the other parts, we just don't know. So we treat everybody empirically and we just say, look, it's retention for life. You're going to keep the teeth perfectly straight. And that usually involves a little bond retainer, which is a little bit of wire that's glued on to the backs of your teeth in conjunction with mouthguard type retainers you'd wear on the night. And that's really the only way to keep the teeth nice and straight. So when it comes to orthodontics, who can carry it out? So myself, I'm an orthodontist. I know dentists who do it, and I know orthodontic therapists do it. Usually the orthodontic therapist does it under the direction of a dentist or an orthodontist. I worked with lots of orthodontic colleagues, and when it comes to that, they just follow my prescription really, and that's how things are in the UK, North America, and Australia. They follow prescription, and generally, when I'm using an orthodontic therapist, I'd like to see the patient every other visit. And the plan then is onward going and formulated. But those are the sort of people that do it. Again, when it comes to the orthodontics, the main two reasons we do it is to improve function and also aesthetics. This little girl is my daughter. And that she was about 10, I think 10 and a half. So her teeth were a little bit crooked, but the main thing with my daughter is her teeth stuck out. So I sorted her teeth out for her, and then she stopped riding horses and got into makeup and boys. so, so it wasn't the orthodontics that was responsible for that, but you know she's gone from somebody that was into the sports and the horses, and then somebody that has become very conscious about appearance and likes to look good, and they all do their selfies these days. That's all they seem to do. But she's had a nice result. Her teeth are nice and straight, and she's done well. She's a chemical engineer now back in the UK, so she's traveling all over the place. But yeah, so I think we achieved a nice aesthetic result. She's got a nice smile. We can't really do anything about the soft tissue pattern, the jaw pattern. Her lower jaw is still set back, and she's got a short upper lip. And when she smiles, it comes up like a little Venetian blind. But that's just who she is, and that's it. If you wanted to do something about that, you could probably use a little bit of Botox to inject in that area to stop the lip coming up like the blind. But you know, she's happy as Larry, and must wear a mouth guard for contact sports after you finish orthodontics. When it comes to orthodontics, there are really two timelines. The first timeline is what we call interceptive orthodontics, and that's generally under the age of 10. The treatment objectives tend to be limited in terms of what we can achieve and what we're looking to carry out. And I always warn parents, look, you've got X, Y, and Z wrong. It would be good to sort that problem out now, but they will need treatment when they're older, but the treatment's going to be easier and the appliances are less complex because some of the orthodontic appliances that we use are complex. And I'll show you a couple of those shortly. So that's why we would do sort of interceptive orthodontics. How am I doing for time? Am I all right?
Yeah.
Okay. So a lot of the time with interceptive orthodontics, we need to gain a bit of space and fix points. And these are two expander appliances. The one on the left, that's basically what we call a rapid maxillary expander. And that's actually glued into the teeth. There's a direction you can see with the arrow, and that arrow is generally turned maybe once or twice a day over a sort of like a 10-day period. Then we review things, check the expansion, and then he would hold that for 6 months. If you take it off before 6 months, you lose 50% of the expansion. So generally, we leave it in for about 6 months, and then we give them a little plate. And the little plate is to stop these back molars coming forward, preserving what we call the leeway space. And that's the difference between the width of the baby molars and the adult premolars. And you gain about 2.5 millimeters. That doesn't sound a lot, but that's like 20 yards to a layperson when it comes to comparing it with an orthodontist. So 2.5 mil is good. And this is a removable plate. It depends on the clinical situation, which one I use. I generally try and use fixed because removables, kids take them out. And even in the best will of the world, I know my daughter would have been fine with either fixed or removable. But my son, if I'd given him a removable, because he did a lot of sport, he would take it out, put it into his box, do the sport, and then 4 hours later, my wife and I would say, "Where's your plate?" "Oh, it's in my bag. It's in my bag." "Yeah, it's fine." "Oh, I've left my bag at school." So that's the sort of thing, because we know with regards to removable appliances from studies that have been carried out, compliance is the main issue with achieving your treatment goals. We also sometimes put what we call space maintainers in. The one on the left, that's what we call a transplate large. This is one you can take in and out. It's got some little slots on a gate there, and you just slide it in and you just bend the wire up, and then that has the advantage of basically being able to sort of take it out. And then this is what we call a band and loop. And again, we use it for specific clinical indications to do that. The aim is to try and preserve the space. We don't want the molar drifting forward, because if it drifted forward, it's going to compound the crowding. In other words, it's going to make the crowding worse. So that's why we do it. So if somebody asks, "Oh, my son or daughter needs a space maintainer, why?" You should be able to answer that now. But it's just going to make the crowding worse to keep the space. Right. Okay. So this is at the top on the left. That's a rapid maxillary expander. On this bit on the bottom is the component of what we call a cantilever bite jumper. So this is definitive orthodontics, and this is 2-phase treatment. So the first phase is using what we call this, which is called a fixed functional appliance. That coordinates the arches, in other words, addresses any transverse discrepancy. And then these are connected by some little piston arms. and that's actually going to reduce the sticky outness of the teeth and what we call the overbite. The sticky outness is called the overjet, and the vertical overlap is the overbite. So that will address, a big overjet and actually overbite. So somebody whose teeth are sticking out and the bottom teeth are biting virtually in the roof of the mouth. So again, fit the expander, do the expansion, have a pause, and then 8 weeks later, we fit most of the top braces and the bottom ones. When you put the expander in, one of the things we look for is this gap at the front. That's what we call a transient diastema. And that indicates that we've got some good expansion. I took this photograph because I don't often see it. Because normally when they come back to see me, it just closes up together, so we don't get it. But you can see that this patient, we put the braces on, and I thought, oh, we've still got an diastema. Must get a photograph of that. He was a little bit. I think his mum got him up early, so he's a bit fed up. So ideally, I could have dried it off a little bit better to get a better of a photograph. But I just wanted a quick snapshot of that. So, and then this type of appliance, this fixed functional appliance, is normally on for a year. So we take it off, and then they'll be left with fixed glued on braces, top and bottom, and just elastics.
Charlotte has to go to work.
Yes, right. Yeah. Nice to see you. Yeah. So traditionally, what used to happen, functional appliances, especially in the UK, are removable. They'd be on for about a year. Then there'd be what we call a transitional appliance, and where a different type of appliance with a little ski ramp at the front. And then they wait a little while, and then they have the braces put on. The reason I do it this way, it reduces the treatment time. So roll the two phases into one, reduces the treatment time by about 6 to 9 months sometimes. Yeah. These are a mainstay of single phase definitive orthodontics. And you've got metal braces, and these are what we call brackets. That's the technical term we use. That's the wire. Those little metal bits are what we call stops, and then we've got ceramic brackets. Most adult patients, if I can't do the case using removable aligners such as Invisalign, they tend to opt for the ceramic brackets. And it's just, they look a little bit nicer. They're not as visible as the metal one. Yeah. So generally we wait until all the added side teeth come through. So usually about 12-ish onwards. My daughter, all the teeth, side teeth came through, and she was ready to go at 10 and a half. So we started orthodontic treatment early. By the time she'd finished, a lot of her friends were just starting. Yeah. As I say, the main indication is to get everything done to improve function on aesthetics. I apologize about this slide. Again, I had to borrow one because I didn't have one of those. But that's somebody that's using basically removable aligners such as Invisalign. On all of these treatments, the treatment generally runs between about 12 to 24 months. Sometimes patients will say to us, "How long is it going to take, Doc?" I say to them, on average, this usually how long it takes. And I'm not trying to be difficult and dodge the question, but everyone's different. And sometimes we just don't know how the teeth are going to move. Sometimes in some patients, the treatment, the teeth move really quickly, and other times they move really, really slow. Until you actually start treating the case, you just don't know. And it's not that we're trying to avoid the question or be difficult. It's that we honestly just don't know how the teeth are going to respond and how that individual is going to respond. When we finish orthodontics, excuse me, we mentioned about retainers. Now, interceptive orthodontics, normally we give a little removable plate it looks like the original plate that I showed you for an expander, but hasn't got this screw in between. And that's just to basically stop the adult molars coming forward, trying to preserve that leeway space we talked about. But definitive orthodontics, it's normally a combination of both. So you've got the wire on the bottom teeth, 6 bottom teeth, and then you've got the removable type retainer called a vacuum form retainer, and it just uses a vacuum when we construct that. This patient would have had an upper bonded retainer as well, and that's usually either 6 upper teeth or 4 upper teeth, and again a removable retainer that's worn on a night. So that's sort of like orthodontics in a nutshell. When it comes to referrals, we'll happily, I recognise that some of you are really busy, and if you've got any patients you'd like us to see, I'll happily take a call. Sometimes if it's in between patients, I'll ring you back. I don't mind people having my mobile number. The best time often is in the evening. I know it's it's one of those things, in terms of encroaching, but I don't mind people ringing in the evening because that's usually after about 7 o'clock when things can slow down a little bit. I've just got a bit more time. But
when should doctors, so say in terms of pediatrics and young children coming in, so this is 18 months of orthodontics when I was a kid as well.
yeah.
And I had